Assalamu alaikum again. Uh, it gave me a true pleasure to introduce the next speaker. I don't think he needs any introduction. He's a well-known physician, worldwide recognized for his work in many disciplines, including lupus, particularly in the components of observational studies as well as clinical trials. Professor Munder is dear to my heart. They gave me the introduction, but I will introduce him from my own aspect. He's a great physician who helped developing lupus programs and lupus research in different disciplines and different areas. He has been working in St. Thomas Hospital in London, where he did and direct the lupus research there for a period of time. He also is interested to promote research in our region. He moved to Dubai recently in the last couple of years to establish lupus research there, and he has promoting and supporting many of the young investigators in our region, including myself, to promote research in good clinical standards and support the research initiative, including our lupus cohort at King Saud University Hospital. So without further delay, I would like to welcome Professor Munder to give his talk shortly. I'm always technically
Just give me 1 minute to.
Yeah.
Thank you. Just let me 1 minute to share with you my slides. Thank you very much for the introduction.
Most welcome.
It is an absolute pleasure to address the Saudi Society of Rheumatology once again, and it's always a pleasure to come to your meeting and share with you a few minutes of pleasure and sharing some science with you. I know we are out of time, and don't worry, because this lecture will be given again on the 16th of June when we launch the drug, Subcut, Benlysta Subcut, in another session, which is about 16th of June on Wednesday at 8 o'clock. So if we don't have time for discussion, we can catch up in the 16th of June. As mentioned, I am now retired from clinical practice and joined the company GSK in about a year and a half ago, and I'm full-time employee by GSK. Let me tell you a little bit about the design of the Subcut that we have now licensed in many parts of the world and recently licensed in Saudi. So we did the study, which was based in a randomized control trial, 2-to-1. What's the meaning 2-to-1? We wanted to make sure that we have more number of patients with Subcut compared to the standard therapy, and you see later on the presentation that we have 280 patients receive standard of care plus placebo versus 556 patients who receive belimumab Subcut 20 milligrams weekly plus standard of care. And this is a large number of patients. We stratified at screening for Serena Sledi 9 or below or 10 and above, complement C3 and C4 low or no, and black or other races. The objective of the study is obvious: efficacy, safety, and tolerability of belimumab Subcut, which is fixed dose, 200 milligrams weekly, plus standard of care in patient with active autoantibody positive SLE at 52 weeks. It's important to always look for inclusion and exclusion criteria. They were exactly the same like BLISS 52 and BLISS 76 for the intravenous formulation, which we did many years back. This year we celebrate the 10th anniversary of launching Benlysta intravenously. But summarizing quickly, all patients included in the study have to fulfill the ACR criteria for SLE, positive anti-double-stranded DNA and or antinuclear antibodies, and Serena Sledi has to be more than 8. This is a major differential from BLISS 52 and BLISS 76, which the Serena Sledi was more than 6. And exclusion criteria, we excluded, like similar to the BLISS 52 and 76, severe active lupus nephritis. We excluded severe active CNS lupus. If the patient are pregnant, also were excluded. Those who received, for example, rituximab over the last year were also excluded. Patients who received another experimental medicine over the last 60 days were excluded. Patients who received anti-TNF or cyclophosphamide were excluded, and patients who received live vaccine over the last month were also excluded from this study. Primary endpoint of the study was SRI-4 responder at week 52. As you know, SRI-4 responder is a composite score which requires 4 or more points improvement in Selena Sledi, no deterioration in BILAG, and no worsening in the PGA, which is Physician Global Assessment. You have to fulfill these 3 criteria to be considered as responder at 52 weeks. We have about 4 major secondary endpoints, which is the time for severe flare, reduction in glucocorticosteroids. We assessed fatigue and also safety and adverse events. We have a special subgroup analysis. As you know, we know from the intravenous formulation, the best responders who are with high disease activity, with low complement and high double-stranded DNA, and this subgroup will be analyzed separately as well in this randomized control trial. As you can see, the number is huge number of patients were recruited in the study. 280 received placebo plus standard therapy compared to belimumab 200 milligrams subcut weekly plus standard therapy, 556 patients. The female were 95 to about 94% of the patients, age about 38 to 39. Hispanic was 1/4 and non-Hispanic about 70%. Selena Sledi average was about 10 in both groups, and medication were equally distributed between the 2 groups: steroids, immunosuppressive drugs, antimalarials, and combination of these. There is no difference at all between the 2 treated groups. This is the major outcome measure, SRI response at 52 weeks. As you can see clearly in blue, at the end of the study, 61.4% responded compared to 48.4% in the control plus group. The response started at around 8 weeks and became significant around 16 weeks. So you have to wait about 3 months to have noticed some response when you treat with subcut formulation. In the left side, you see the intention to treat population, i.e. the total population, and in the right side, the high disease activity group, which with those with low complement and high double-stranded DNA. And in this slide, you see time to first severe flare was significantly reduced with belimumab plus standard of care compared to placebo plus standard of care. Especially, you can observe that 31.5% in the placebo arm with the high disease activity compared to 14.1% in the high disease activity, which is extremely significant difference. Steroids as secondary endpoint in this important study, although it did not reach statistical significance, you see the tendency that those who received belimumab have in both groups intention to treat population, which is the total population, and in those with high disease activity, they have tendency to have less steroids in their regime compared to those who received only standard of care plus placebo. Fatigue is a very important factor in patients with lupus. As I mentioned in my previous lecture today, fatigue goes hand in hand in lupus. If a patient has no fatigue, even without the diagnosis, fatigue is almost 100% of patients suffer from fatigue in lupus. And interestingly, in our studies, both in intravenous formulation and in the subcut formulation in this case, fatigue response is very quick. By 8 weeks, we have difference, and this remains significant towards the end of the study and becomes significant at 36 weeks at the end of the study as well, compared with subcut in the total population, and it was also significant in the high disease activity group towards the end of the study. It was 5.4 versus 3.6 in the standard of care plus placebo. So both in the intravenous formulation and in the subcut formulation, fatigue response is excellent. In fact, one of the first manifestations to respond in both studies is fatigue. It's important to look at adverse event. And let's start with high disease activity group. So with the high disease activity group, as you can see, adverse event occurred with similar rate in both groups, in the placebo plus standard of care compared to belimumab, 200 milligrams every week plus standard of care. About 80% have adverse events. Serious adverse events such as infection and infestation, renal and urinary disorders, and vascular disorders were similar in both groups. If anything, they were less frequent in the belimumab compared to the placebo arm of the study. When we look at adverse event of interest in the whole population, you see malignancy was very few patients have malignancies in the whole study, two in the belimumab and one in the placebo, but there is no difference. Post-injection systemic reaction was minimal in both groups. Serious delayed non-acute hypersensitivity reaction, 0 in the belimumab and 1 in the placebo arm of the study. All infections were similar in both groups. If anything, was slightly higher in the placebo arm of the study. Opportunistic infection, the same. Herpes zoster, please note, there's no difference between the two groups, or sepsis. So we don't have any major issue comparing both belimumab and placebo group, which was similar of the intravenous formulation. So there's no signals that we have to worry about when it comes to adverse event. The rate of adverse event of special interest, like herpes zoster, sepsis, depression, suicidal thought and suicidal behavior, even deaths, there is no difference between the two groups in the high disease activity group. So who is the candidate for Benlysta, generally speaking? Well, those with high disease activity, for example, positive anti-double-stranded DNA and low complement, those with mucocutaneous manifestation, immunological manifestation, kidney and musculoskeletal manifestations, persistent disease activity who requires glucocorticosteroids, or for some reason they are not able to taper steroids. And as I mentioned before, is excellent drug when you have patient complaining from severe fatigue. When we should start the treatment, there is data from observational studies that within 2 years of the SLE diagnosis will have the best response. Ideally, before you accumulate damage, because once you have damage, the response is less effective. Before you have SLEDAI damage index or SDI index less than 1, inability to taper glucocorticosteroid doses to acceptable dose, which is 7.5 milligrams daily. And when those patients with inadequate control of the disease with standard therapy, which is hydroxychloroquine, steroids, plus or minus immunosuppressive drugs. Now, we did a survey, a small survey, is not a huge number of patients, 43 patients, who were treated with originally with intravenous formulation, and then they switched to subcut formulation. And we interviewed these patients to see about their experience and their preference. And as you can see, 3/4 of the patient preferred the subcut formulation. And when we look at their symptoms, comparing the two formulations, much or somewhat better, 40% of the patient, no change between the two formulations in 1/3 of the patients, and in 20% of the patient notice much or somewhat worse with subcut formulation. And it's obvious why the subcut formulation is preferred by the patient, because it's convenient. In 71% of the patients, about 1/4 self-infection, self-administration at home is, I prefer to do that myself. It's quick administration, it takes 2 to 3 minutes to do, and shorter administration time. Easy incorporation into daily routine. Remember, patients with lupus are young patients, many of them are working class, and to take it at home and or do it at home or do it at work is not a problem, rather than going to the hospital and spend the half day in the hospital. So lastly, I would like to finish with a couple of slides about how to switch from intravenous formulation to subcut. We are lucky because the pharmacokinetics showed you can do this very slowly. You can do it after the last injection, 1 week after the last injection, 2 weeks after the last injection, 3 weeks after the last injection, and even 4 weeks after the last injection. So you can do it gradually whenever you want. The administration is ready, is given once weekly, as I mentioned, and is not based on weight. The weight is not relevant here. Intravenous formulation, 10 milligram per kilo, but in the subcut formulation, whether your weight is 50 kilograms or 100 kilograms, is still the same, 200 milligrams per week. And loading dose is not required. As you know, in the intravenous formulation, we require day 0, day 14, and day 28, then every 28 days. Here, there is no need for loading dose. And as I mentioned before, you have you have 1 month to choose when to start the subcut formulation. 1 week, 2 weeks, 3 weeks, or 4 weeks after the last intravenous infusion.